This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new here, welcome. And for those of you who are regulars, welcome back. As you know, I'm a MedPeds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the wonderful Paul C. Gaffney Division of Pediatric Hospital Medicine. And we've been coming to you for 10 years now. This October, I've been saying it all year. Get comfortable. I'm going to keep saying it all year. This October is our 10-year anniversary of the podcast. We've been coming to you for a decade, and I always want to thank you all for letting us come into your earbuds, your car, or wherever you're listening to me. And I appreciate having the honor of doing this for the past decade. Now, today's episode is something I haven't done a lot of on the show. We haven't done a ton of rheumatology. And a part of that is my own comfort with the topic. I'm going to be very upfront with you. But I was in a grand rounds at Children's Hospital of Pittsburgh back in December. And this particular topic just blew me away. The speaker, you're about to meet her in a second, was wonderful, clear expert in the area, and the changes that have come in this area I did not expect. So I thought we got to have this on the podcast. So without further ado, let me introduce to you our expert guest to walk us through scleroderma and how it's changed and what is going on. Is Dr. Kathryn Torok, who's a pediatric rheumatologist here at the University of Pittsburgh and UPMC Children's Hospital of Pittsburgh. She directs the Pediatric Systemic Scleroderma and Craniofacial Scleroderma clinics. And for over 15 years, she's led national, clinical, and translational research focused on improving outcomes for children with localized and systemic scleroderma. She's a principal investigator of the National Registry for Childhood Onset Scleroderma, NRCOS, the largest U.S. registry and biorepository for pediatric scleroderma, integrating clinical data with biospecimens to identify disease mechanisms and biomarkers. And Dr. Torok has developed validated clinical and patient-reported outcomes, tools, and collaborates internationally to advance therapeutic discovery. She also serves on the Pediatric Scleroderma Steering Committee of the CARRA and mentors future physician scientists right here at the good old University of Pittsburgh. So, Dr. Torok, thank you for joining us.
Thanks so much, Tony. I'm excited to be on this podcast today.
Well, Cassie, this is a CME podcast, thanks to the University of Pittsburgh, so we got to do our disclosures. So I will go first, and I'll kick it out to you. So I have nothing to disclose.
Yes, I don't have any relevant disclosures.
Wonderful. Now, Cassie, like I was saying, when you were giving this grand rounds on December 11th at Children's Hospital, I didn't expect the changes and advancements in pediatric scleroderma, and I was really excited to bring this to the podcast. So I guess if you're comfortable, we can start with just defining scleroderma, kind of like back to Rheumatology 101 for our first year med student, let's say. What are the types? Can you define it for us?
Sure. So scleroderma actually comes from the Greek word scleros and derma. So sclero is hard, derma, skin. So that is the overall root of scleroderma. And then within that, there's two major phenotypes clinically. So that would be localized scleroderma, also termed as morphia by the dermatologist, but localized scleroderma by the rheumatologist, making it even more confusing. And then the other subtype is systemic sclerosis or systemic scleroderma. Now, the two are similar, and why they're kind of under the same umbrella is because if you actually biopsied the skin and gave it to the dermatopathologist, they would not be able to tell you that it's localized scleroderma versus systemic sclerosis. They look exactly the same with both an inflammatory features and fibrotic features. So that's kind of what links them together is probably the pathophysiology, but clinically they're very divergent. So localized scleroderma or morphia is what the clinicians that are probably listening to the podcast are going to see more often, still rare, but I would say it's about as common as type 1 diabetes, so it's not that rare. It just ranges from more mild to severe. These are typically like linear bands, or linear scleroderma is a subtype of the localized, either like on the face, sometimes called in coupe de sable or sort of the saber, linear down their arm, patches on their belly. Those are generalized plaque morphia. And those, though there's some superficial changes, they can have some significant impact, especially if it's on the face, it may affect the brain. And then if it's kind of on the arms or extremity, it can give you joint contractures, kind of like rheumatoid arthritis, where you can have a joint contracture from deep tissue involvement. So that's the localized scleroderma or morphia. And then a quick synopsis of the systemic sclerosis or systemic scleroderma is what you would learn in medical school for one day, usually the last day of your second year. But basically, it is under the adult rheumatology block typically when you learn that, but it's the patients that have the thickened skin everywhere. So not just the bands that I mentioned, but starting from the distal fingers and feet, moving up centrally, and then really involving almost all of the surface area of the skin. And then with that, you get contractures like the claw hands you might remember from medical school, where the patients have trouble opening and closing things. They'll get Raynaud's, where about 95% of them. So that's the triphasic color change with stress or the cold weather, etc. And then they can get digital ulcers on the tips of their fingers from the Raynaud's. And then the most troubling thing is 40% of them have interstitial lung disease. So that's inflammation and fibrosis in the lungs, and that's a major burden for these patients, as well as some other multi organ system involvement. So that's the two clinical phenotypes, which are very divergent, and systemic sclerosis in kids is much more rare. In your general rheumatology academic center, you might have 1 to 4 that the group of 4 rheumatologists follow. I'm a referral center, so that's a horse of a different color. I have about, like, 100, but that's a different story. So I think knowing, how to recognize both is important, but just for the clinicians listening day to day, they'll see the localized scleroderma more often.
That was a wonderful synopsis. Thank you, Cass.
Mhm.
Now, in your presentation, you talked a bit about how our understanding of this disease has changed over the past 1 to 2 decades. Could you walk us through that again? Because I found that really fascinating.
Sure. So to go back, both of these are autoimmune disease. So typically you're not born with them. It's just your immune system is constantly evolving. You and I, every time we encounter a virus or whatnot, every person's immune system's altering. But then what happens in autoimmune world is that something is turned on and starts to recognize self-antigens as foreign. So whether we're talking about juvenile arthritis, autoimmune Hashimoto's thyroiditis, or scleroderma, it's the same concept. This is this overstimulated immune system. So that's why we typically use our medicines to immunosuppress. So that's the global understanding. The newer understanding is with some of the newer technologies like single cell RNA-seq, things like that. And I do this in my lab. We can actually biopsy the skin and look, under the basically flow cytometer and under the microscope with spatial transcriptomics and see the exact genes being expressed that are altered in the skin compared to healthy skin and also in the peripheral blood. So we know a little bit more than T cells are a big player, as well as some of the macrophages. We think those kind of stimulate the inflammation around the vessels, and then that kind of triggers down to the fibrosis. So a little bit more of that understanding is yes, we've been using methotrexate and steroids to some degree for years. I would say 30 plus years when we look at it. And that is actually pretty effective. It's like 75% efficacious, and it helps get the skin thickening down, prevents newer lesions, but it has a lot of side effects. So about 30% of the kids, at least, probably more, get nausea, fatigue, things of that nature. It's not very well tolerated. So more recently, and this actually my undergrad Pitt student who's going to medical school next year, Elena
Mm.
DeRosa's first author publication just came out showing that mycophenolate mofetil is just as equivalent as methotrexate in our longitudinal observational cohort. So that has a way better side effect profile and, is just as effective. We looked at the efficacy as far as the cutaneous outcome measures, both improving the same rate and then sustained remission on the medication. We did some Kaplan-Meier curves and saw that they're equivalent. So that's brand spanking new as of a month ago,
Oh,
published
wow.
in
Look at that.
yeah, published in JAMA Derm, which is pretty big. So we're excited about that. So that's a game changer because the tolerability and its equivalent, and that's what we just call our standard disease modifying anti-rheumatic agents. The next level that has been new for localized scleroderma are the biologics. Same with systemic scleroderma. I'll talk about systemic in a minute, but Orencia, tocilizumab, those biologic agents have been really helpful for kids that have the localized scleroderma, especially if it's causing deep tissue arthritis, tendonitis, joint contractures. So That's also been pretty new in the past 10 to maybe 15 years. So even when I was a fellow, these aren't things that crossed my mind, to be honest. So these are all new. And I'm working with a group internationally called SCTC, the Scleroderma Clinical Trials Consortium, to actually develop a protocol where we randomize patients where to MMF, which I said is kind of equivalent to methotrexate now, or some of these biologics, Orencia, tocilizumab, and a JAK inhibitor. We're doing that because we use these medicines, the biologics, but we feel like we use them late in the game. Oh, they already failed methotrexate. Oh, they already failed MMF. So then we're giving them these agents so that potentially when that trial, hopefully, we got funding to design the trial. But
Okay.
if that trial gets funded, that will be a huge game changer because you might walk into your localized scleroderma treatment without, instead of a broad treatment like methotrexate or MMF, but a more targeted treatment like an IL-6 inhibitor. So that's brand new kind of development that's going on right now. And then as far as the systemic scleroderma, that has been definitely different since I trained Dr. Metzger, who Dr. Tom Metzger is a world-renowned systemic sclerosis expert here at University of Pittsburgh. Their cohort is at least 10,000, which is one of the largest in the nation. So I trained with him, and at that time they were barely using methotrexate and then only Cytoxan for bad lung disease. But that was about it. So since then, the biologics have come on the scene. Actually, tocilizumab is now FDA approved for adult systemic scleroderma, interstitial lung disease, and a medicine called nintedanib, which is kind of an antifibrotic as well for ILD. And in addition, the kind of cool thing that you saw me present at Grand Rounds is the autologous stem cell transplant. So that has been a game changer for systemic scleroderma. The big trials came out in the New England Journal of Medicine back in 2018 for the adults, and they showed that IV Cytoxan, which is like the standard for bad interstitial lung disease or bad cardiac, other like severe organ disease, compared to the stem cell transplant, that the stem cell transplant had a much better survival rate in and of itself, and then also kind of 3-year, 5-year better overall like comorbidity issues, like their quality of life was better, their mobility was better. So kind of a composite score was significantly improved. So that was a game changer for the adults, and a couple of different stem cell transplant programs have been up and running for them. But I tagged on here because we have a program that we started back in 2008, around there, 18, 19, right when that article came out. Paul Sabolks here at the University of Pittsburgh, Children's Hospital of Pittsburgh, is very cutting edge for non-malignant bone marrow transplant. So he jumped on with actually the adult rheumatologist, Dr. Metzger at the time, and Robin Domsick, and they actually developed this original stem cell protocol for Pittsburgh. But then I hopped on maybe 2, 3 years later. And remember, Paul Sabolks is a pediatric, but this was first developed for adults. They just needed his help because it was kind of cutting edge, non-malignant BMT. So I hopped on maybe 2 years into that, and then we modified it. So now there's a cohort 1, which is 8 years old to 24, and cohort 2 is 25 and up. So at that modification, we've been enrolling more and more patients. And now we have done the autologous stem cell transplant here at Children's on 9 patients. The ninth patient just had his 12-year follow-up and looked fantastic. His mom
Oh,
just gave me a huge hug, and he's going back to school. He's keeping up with the family on their hikes, things that he couldn't do before. His Raynaud's is much more under control. He just has a lot of more like spirit back and just global health. He just looks so much better. And then we've just enrolled 3 more, just signed the consent to do the stem cell transplant. So it's life-changing for these patients. I mean, he's a more mild example, or my more significant example I think I showed at Grand Rounds was I have at least 2 patients that were kind of bed-bound. And one was in a hospital for a year and a half, and the other one was in a hospital bed in her apartment. And they basically had to have at least 2 adults help get them out of bed. And these were kind of like 17, 18-year-old girls at the time who were kind of like star basketball players, go, 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 had 3 jobs. This was not their normal to be so contracted and bedbound, and they couldn't even really walk without a walker. So to see that after the stem cell transplant, 6 to 9 months that they're walking around, skipping, and then by 12 months, my one patient was literally running down the hall and dancing and did not think that that was physically possible, to be honest, to reverse fibrosis that significantly. That's the game changer. That's brand new as of, these last couple years. So it's exciting to be part of this. Then it's dovetailing into something that you guys, other people may hear in general that are listening, is CAR T therapy. That's kind of engineering the T cells with the virus basically to kind of then go hone in and attack the B cells. And this is popular in a couple different autoimmune diseases: lupus, dermatomyositis, scleroderma. The adult trials are looking really promising. So we're actually starting some of these trials here at Children's Hospital of Pittsburgh as well. So we're excited for that. There's also in neurology land, they're doing CAR T therapy as well for MS and myasthenia gravis. So that's why I'm saying it might be kind of a bigger spectrum than just rheumatology. But we borrowed that technology from BMT because originally for lymphomas, it's pretty effective. So anyway, that was a long answer to there's a lot of new stuff going on in both localized scleroderma and systemic scleroderma for the better of the patient. I'm really excited to be part of this kind of wave that's changing and hopefully a better future for our kids that grow up to adults.
Cassie, that was great. And it brings up, there's like two or three questions in my head here. Now, in the rheumatology community for the systemic scleroderma, when you started doing the bone marrow transplants or the stem cell transplants, was it a surprise that the fibrosis reversed? Because to me, I would have assumed fibrosis is there. Once you have it, it stays there. But the fact that you're saying it reversed in some cases, was that a surprise? Was that expected?
Oh, total surprise. I mean, I'm still shocked. My video didn't work for Grand Rounds, but it did work. I was just at the PRISM meeting, which is the Pediatric Rheumatology Symposium in Minnesota, and I was able to show the video of that one patient I mentioned where she was kind of like bedbound and then like dancing down the halls 12 months later. And I just stopped and I was like, I don't know how this is possible, guys. Like, I did not think she's 6'3" and she was hunchback. She couldn't even,
Yeah.
she was frozen in the videos. And then to be able to stand up straight and dance around, I did not expect that, to be honest. I expected some improvement. I didn't expect that degree of improvement. So that's what I'm doing research now on, though, is I saved their peripheral blood cells and I did skin biopsies baseline 6 months, 12 months, 24 months for that reason, to then see how the cellular kind of milieu changes over time, and then what is like an effective immune reset and what might not be an effective immune reset. So I'm looking at that on the bench side of things.
And then for your localized scleroderma, as you're starting, you talked about the trial that you got funding just to plan for the
Mhm.
biologics. Are you, in your expert opinion, you haven't done the trial yet? Would you expect the biologics to really significantly improve quality of life and morbidity in localized scleroderma?
I do, but more from a tolerability standpoint. I feel like these days, those biologics I'm mentioning are pretty safe. I mean, you just have to be, following with your rheumatologist every 4 to 6 months. But Orencia, tocilizumab, JAK inhibitors in general in kids, they're pretty safe. Now, adults a different story. They have some comorbidities like hypercholesterolemia, hypertension, and things like that. But in kids, they actually tolerate these meds quite well. And what I think, Tony, is that right now methotrexate is like 80% of all of the juvenile scleroderma patients around the world are on methotrexate, which is, again, effective. But I can tell you, I just talked to a family last week where they're like, oh, little Susie, like she feels sick for 2 days. She misses school for a day or two. We're both working parents. We have to find a nanny. Like, it's multifactorial. So both feeling bad for the child, but then it's very disruptive to the whole family as well. So I think as far as a overall like tolerability of the medication, while still not risking too much infection and other side effects, I do feel like the biologics have a good place in this condition for sure.
That sounds fantastic. Now, one of my favorite things you talked about is in systemic sclerosis, or yeah, systemic
Mhm.
sclerosis in kids. You talked about the incidence, and you also talked about how long it takes to diagnose this condition, from when symptoms start to when a diagnosis is made. I would love to review that because that's something that sounds like a hospitalist could see.
Right. No, so that's a great point, Tony. So typically about a year and a half to 2 years till the patient actually gets diagnosed with juvenile systemic sclerosis. And obviously, you want to intervene as soon as possible. It's hard because it's rare, so I understand. But the key things would be, Raynaud's is pretty common in the general community. I would say about 10 to 15% of teenage females have Raynaud's, but if you have Raynaud's in like a 3-year-old or a 4-year-old, probably worth kind of just digging a little more history, and even seeing like that's the one where it's okay to order an ANA. Usually we do not like you guys order ANA or
Hmm.
rheumatoid factor, but like a 3-4-year-old with Raynaud's, not just acrocyanosis. So acrocyanosis is like your hands and feet. You're just always like a clammy, kind of
Hmm.
like bluish hand, foot kind of person, a little sweaty. That's a little different. Raynaud's is literally it's their phases. So the kids walk around, has hands look fine, and then literally it's usually like 2 fingers. It's not just like the whole hand. It's like 2 fingers, you're out in the cold, and they're just like white, like stark white, numb, cold, tingly, painful on rewarming. So when you rewarm it, that's actually when it's the most painful. So those would be kiddos that you might want to like get a better history, better exam, ANA, and then send them to rheumatology if you're like, I'm just not sure what's going on. So 5, 6, 7-year olds, something like that with Raynaud's. Now, a teenage girl with Raynaud's, I wouldn't necessarily go too crazy, but if they have other things going on that you can't explain, like persistent arthralgias and things like that, I think that would be reasonable again to order the ANA. And when I say ANA, like that's good in of itself, but you really need like a CBC, a CMP, a sed rate CRP to go with that. Like you need to know the general typical labs. What are they doing? But the biggest thing that we would say is to tip you off that it's scleroderma would be if you ever have digital pitting ulcers. So the little ulcers at the tips of the fingers, if that happens at all with Raynaud's, 100% abnormal, send to rheumatology. You don't even mess around with ordering blood work or whatever. Like, just send them to us. We'll figure it out. I've had kids come with systemic sclerosis with the digital ulcers. They'll go to cardiology first. They'll go to derm first, like trying to figure it out. But that's your clue. If you have Raynaud's and you have those digital tip ulcers, send to us. It's going to be scleroderma or some related connective tissue disease. It's not normal to have ulcers on the tips of your fingers. The other thing I would say is obviously any skin thickening. You know, they have like these swollen, thickened looking hands or arms, you know, things start kind of stiffen up and you kind of move their elbow or something, you're like, oh, it's not moving. You ask them to do a prayer sign and they can't do that. They can't extend their hand and their wrist at the same time. You know, those would be kind of signs that maybe some scleroderma is going on. So those would be the main things. Oh, the other thing with Raynaud's is not everyone has a nail fold capillaroscopy at their handy use. That's like a
Sure,
derm
sure.
thing. Yeah, like a derm scope. They look for melanoma mostly is what they're looking for. But you can see from across the room if you look at the kid and the distal nail folds look like weird, then they look very kind of like hyperemic. The loops look funny. There looks like there's hemorrhages. That would be another reason to send them our way that it might be scleroderma. So those are the main, like, outward signs, I would say. The more subtle signs are, you know, in what I was talking about, grand rounds are like failure to thrive. So not every failure to thrive is going to be scleroderma. Scleroderma is so rare. But if it's failure to thrive and something else is going on, like they're just not gaining weight, they're falling off the curve, and then, yeah, they have like these really tight hands. What the heck? You know, that might be a sign it's scleroderma. So that's one of the kind of subtle things that can happen as well. The ILD, honestly, you're not gonna get early. The kids just, like, stop if they're doing sports, they're just, like, stopping to do certain sports. They typically won't have this, like, cough or anything, like, none of the classic signs early in it.
So you're not gonna have like a patient with scleroderma in pediatrics who's also morbidly obese. You're not gonna see that because of the condition really causes weight loss issues.
That would be extremely rare. I've had, like, 1 or 2 referrals, you know, not recently, but several years back where they were pretty obese, and I was like, off the bat, I was like, "It's probably not gonna be scleroderma just because that's metabolically, it's I just haven't seen it." So it's not impossible, but it's unlikely.
Now, you hit on 3 or 4 things I wanted to talk about, but one of the things in terms of diagnosing, in the hospital setting, we get imaging all the time, and you
Mhm.
talked about, juvenile systemic scleroderma, interstitial lung disease, and how CAT scan is the best test. And I would love to chat about why that's better than X-ray, and if EQ scans is not as good, and, the P what might you expect in pulmonary function testing if we were to get any of that stuff and it came up? Help us through that.
Yeah, yeah. So say you have an inpatient and you're like, huh, is this lupus? Is this scleroderma? People are a little unsure. It would be totally reasonable to get a chest CT. So these days, a chest CT, if you're in an academic children's hospital, is not that much radiation. It's still radiation, but it's not that much. because you're getting a non-contrast. That's important. Please do not get a contrasted CT. If you get a contrasted CT, it actually highlights the vessels a little bit, and too much, you can get like a false positive ILD. It's just like very kind of fuzzy and vascular looking. So a non-con CT chest usually is not that much radiation. And honestly, for the diagnostic power of picking up interstitial lung disease and then treating, because you don't want to get behind the boat and treat it, because interstitial lung disease, like the skin, is a mix of inflammation and fibrosis. So if you hit that part where it's more inflammatory and there's minimal fibrosis, you might save the kid's lungs pretty much. So yeah, so the chest, the X-ray is garbage. It's not going to show you anything. You don't see interstitial lungs disease on a chest X-ray until you have at least like 40% of your lungs involved, which is just way too late. So that's why like a chest X-ray is okay if you're like, hey, lupus, do they have a pericardial fusion, something like that. But don't stop there. If the chest X-ray is completely normal, is what I'm saying. Like you got to go to the next step if you're suspecting interstitial lung disease at all. And then it can mismatch. And we published that because what happened, and I actually wrote textbooks, I'm not going to lie, like 15 years ago, one of my first textbooks, and I was just going by what was standard, is that you did the chest X-ray and a pulmonary function test. And if those two were normal, you're like, okay, cool, the kid is all right. But in reality, the pulmonary function tests they're very nuanced, right? Talk to Dr. Rosser and she'll tell you. The FVC, forced vital capacity, your diffusion lung capacity, DLCO, and your TLC, your total lung capacity, right? So in scleroderma, you should have your TLC and your FVC is going to be reduced, like a restrictive defect. And then eventually your DLCO, can be low as well. But several patients, if your ILD is maybe like 10, 15, even 20%, you can actually be walking around with a totally normal FVC. It can be like 90 some percent, not a problem. Same as your DLCO. So that's why we don't want to rely, when we looked at this larger international cohort, we would miss 30% of the kids that had interstitial lung disease if we just banked on a normal FVC, a normal like PFTs, meaning FVC. So that's why the screening chest CT is important. Now, the pulmonary function tests are important, but they're important to get like in the beginning in the evaluation, but you don't really want to rely on them until you do them longitudinally. Then you can really see where the kid is at. So if your FBC, you're hanging and the kid's like 90%, 90%, 90%, and then the 80%, it's like, ooh, something's going on, 2 years later. Get your chest CT. If you feel like it was a good test and that was real, that's a drop of 10%. You want to get the chest CT to see if new interstitial lung disease popped up as well. I mean, that's more longitudinal. I'm just letting you know, like the power of the pulmonary function test is not so much at diagnosis. It's just nice to get like that baseline, but it's more the longitudinal follow-up that it's helpful. And the VQ scan's not super helpful. People don't know how to interpret those things anyway, half the time, I'll be honest. but B, like you get so much, the CT scan, the high res, it's so granular. You have like 300 to 400 images to look at. You can really see what's going on as far as like ground glass opacities, the fibrosis or reticular pattern. You can kind of tell a lot from that.
Yeah, see, this is so good so far. I'm really loving this. So now, what I'm about to ask you, for you, definitely will be a basic question, but remember, for us, we don't see this disease very often. So the ACR or EULAR systemic sclerosis criteria, is it widely adopted? If it is, can you walk us through it?
Yeah, so the ACR ULAR, so that's the European, basically the ACR, sorry, is the American College of Rheumatology, and the ULAR is the European League of Rheumatic something. So basically in 2013, they came up with a criteria, and it's more for research purposes, but it's just to help like add up certain points to see if you have systemic sclerosis or not. I think like walking you guys through it, I don't think that's necessary. The big thing to learn from that is that the older criteria was 2000. The old criteria was 2007, and that required skin thickening proximal to the MCP, so the metacarpal phalangeal, so your knuckles. So basically, like your hand up, like your forearm had to be thick. And what the 2013 criteria is, it loosened it up, and they said you can have sclerodactyly. So your fingers can be puffy, but like kind of swollen throughout and like a little hard, but not necessarily like the thick skin. And then the rest of your skin can be normal. So they did that so that you could pick up the early scleroderma patients that were just starting to have that like edematous, like poofy early fibrosis.
Okay.
So So that's the main key to walk away from that ACR-EULAR criteria is that your skin, it doesn't actually need to be like thick all over your body. That's kind of later disease. It's that like poofy sclerodactyly hands. And then the other key thing would just be they do put a lot of weight in the SCL70 antibody. They put a little too much weight in the centromere antibody. That's why I don't want to run it too much by you guys. The centromere, at least in our hospital, is highly false positive.
Mm.
So if you got a patient that you got an ANA for their juvenile idiopathic arthritis and you're screening to see their risk of uveitis, they used to get like a reflex panel, and a bunch of these JA kids are popping up centromere, but they did not have scleroderma. So that's why I don't want to like walk through step by step the criteria. And I actually talked about most of it already about like the Raynaud's, the
Mm.
ulcers, and nail fold changes. The biggest thing is that early poofy hands and feet. The feet can be kind of poofy or swollen. So that's an early sign as far as you saying, hey, how can we catch them early? That's one of them. It's like a persistent swelling and stiffness.
Will there be Raynaud's when they're early on in the early puffiness associated with inflammation?
Yep, yep. So if you have Raynaud's, you have these early these kind of swollen sclerodactyly hands, it would definitely be worth sending an ANA, some baseline labs, and calling the rheumatology friends.
So that I mean, this has been great. So if we're in a community hospital, let's say we're not in Pittsburgh. In Pittsburgh, I can just call you and
Uh-huh.
say, hey, because you're one of my office neighbors, and say, hey, Cass, I got this kid. I think they could be. But if you're in a smaller community hospital, there's not a pediatric rheumatologist around. We've kind of walked through physical exam. You have walked through physical exam findings to think about. You've walked through some of the lab work to get. If you were getting, if you had a patient that was coming to you from a more rural setting, how much workup do you want done? Or is it if there's enough on physical exam, just send the patient, will the workup can happen at the tertiary care center?
Yeah. I would say that's a good question. So, yeah, if you have Raynaud's and you have those digital ulcers and then a little something else like joint stiffness, I would say that's enough to call it connective tissue disease, NOS, right? Like
Mhm.
something's happening. So with that being known, whether we call it's going to be scleroderma or lupus or something, it's probably good to just get a baseline echo and EKG. We didn't get into it, but lupus and scleroderma, lots of things can cause different abnormalities there. So I would get those two. In scleroderma, you can have carditis actually early on, and you can get arrhythmias from the fibrosis in the heart. It's not going through the Purkinje fibers and all that stuff. So EKG echo baseline, pulmonary function test baseline. Again, you just have to take them with a grain of salt. An 8-year-old's not going to give you the best pulmonary function test, but we give it a try. And I would say the CT chest, that might depend on like how convinced you are. Like, oh yeah, there's some skin changes. Then I think it'd be reasonable to get the chest CT. So those for sure. The other ones I think can wait for a specialized center. I didn't dive into it, but there's a lot of GI dysfunction, a lot of esophageal dysfunction. So eventually they'll need an esophagram to look at the dysfunction. But that's something, you could even call and be like, hey, is it worth kind of getting this? But that can wait till a referral. And then the other thing that I think could probably wait till a referral is you probably heard me talk about on the grand rounds would be the 6-minute walk test. So
Mm.
that's basically like it measures a couple things at one time. It's looking at the muscle mechanics of walking for 6 minutes, literally like a PT just walks with you for 6 minutes. So that's kind of your musculoskeletal dysfunction. But then the bigger thing that we're looking for is does the oxygen saturation drop? But that you need a forehead probe or an ear probe because with the Raynaud's with scleroderma, the kids like don't freak out if it's like, oh man, their sats are going down to 80. They're like, they're okay. It's their Raynaud's doing that. So
Mm.
that one I would wait for a referral center. But EKG, echo, pulmonary function tests, and probably a chest CT, I think would be reasonable things in addition to like baseline blood work, right? Just general liver, kidney, inflammatory markers, things like that.
Now, you talked a little about this in terms of children with scleroderma or systemic sclerosis. They're more likely to have issues with weight gain, and you talked about some of the GI issues, esophageal
Mhm.
dysfunction. Is that the cause of the weight poor issues with weight?
Correct. I mean, that it's probably multifactorial, but the main thing is like literally, Tony, they stop eating. Their esophagus has so much dysfunction. Like when you actually do manometry, and they won't complain. They never, ever, ever, ever complain. You do manometry where you put the hose down your nose and you kind of goes in the esophagus. And Bibasu, who's here, would do these all the time, where you're looking at the motility of the esophagus and the strength of the contractions of the esophagus. So the lower esophageal sphincter between your esophagus and your stomach, the pressure should be around like 16. That's normal, 16 or higher. These kids, it's like 8. So it's just like so low that basically food is just like that's in their stomach. Oh, and they have gastroparesis. They're not like moving anything in their stomach. So the stuff in their stomach is
Oh.
constantly coming up into their esophagus. Even if it's not food, it's just acid. So then it's kind of like causing these erosions and changes in the esophagus. So then that's painful. So then they're not eating, and then the esophageal dysfunction. So the propulsion is all weird, so they're not eating. So then that's why you're kind of like not getting that caloric intake. And then they actually have some like atrophy of their muscles and things as well, in addition to them losing weight and their BMI dropping. They're getting kind of lean muscle mass because of kind of the poor nutrition as well.
Now that sounds like that's more you see these kids, this is seen more in the advanced stages, or can you see this early on as well?
It's a mix. I do see the failure to thrive in the beginning, to be honest, but as far as the muscle wasting, that is what is a little bit later, if like it's been 2, 3 years undiagnosed.
And then you mentioned the cardiac issues, the conduction issues. Is that
Mhm.
also that can be an early sign, or that's typically a later sign?
That's
Or mixed?
typically in the first 2 years, actually.
Oh.
Yeah. So it's the patients that are the SCL70 positive. So again, if your suspicion is high, you got the ANA, right? You want to do the next step. The reflex panel would be reasonable, which includes SCL70 antibodies. So that one is associated with in the first 2, 3 years to have myositis or cardiac myositis, and PMSEL, like the polymyositis scleroderma overlap kids. Those ones are also at risk to have cardiac involvement.
Yes, this is just great. So you've talked a little about in terms of what's up on the horizon for scleroderma, whether localized or systemic. You talked a lot about what I loved hearing about was the stem cell transplants, and then some of the biologics. Is there anything else on the horizon? And then how optimistic are you that we can make this disease much more treatable and manageable?
Yeah, Tony. So, I mean, I think that's a good way to kind of sum things up is that all the things I've been saying are actually newer recognized. I mean, I've been trying to give grand rounds and publish as much as possible that this is going on with kids. You really have to like quote unquote look underneath the hood and do these studies and kind of follow them because the kids don't complain. So I think honestly just awareness. I think we're growing stronger in the juvenile scleroderma community just internationally. I think we're like getting more and more folks' attention, and then I'm mentoring junior faculty as well to kind of help promote this as well. And actually, the working with the Scleroderma Foundation, I just had a call with them. So we have like a Kids Get Scleroderma too, and we're trying to get more networking for the family, so more resources for the family. So I think education is number one. I mean, we're talking about treatments, but in parallel to treatment, I think the education part of juvenile scleroderma, whether it's localized or systemic, has been a little behind. So we're trying to, like my colleague Suzanne Lee from Hackensack, New Jersey, we co-lead that. Remember you said CARA, CARRA, that's
Hmm.
Childhood Arthritis and Rheumatology Research Alliance.
Hmm.
So we co-lead that for the last 10 years, but we're trying to work with the Scleroderma Foundation to update all the materials on their website, to have like handy QR codes, things like that, that the families can find things more easily. We actually have the Pittsburgh people. We have a scleroderma walk coming up June 6th.
Oh, that's right. Yeah.
That's going to be in Washington. And then I'm flying out to Chicago April something, 14th or something, 16th, and it's a Kids Get Scleroderma 2 only conference. So it's like we have these every 2 years or so, but that's nice so that the families can connect. And then again, we're hoping to stem from that then educational material that can be more available to everyone, and then we can post it up on the National Scleroderma Foundation. So I do see growth and future of just educating people, getting more awareness. I'm actually going to make a video about skin biopsy and stuff like that. So both on the research and general education about the disease. And then the other tier to parallel it would be treatment. And I think we kind of talked about the treatment. It's really that biologic randomized trial that we're working on in the localized scleroderma world, including JAK inhibitors. And then on the systemic scleroderma world, it's keep moving forward with the stem cell transplant therapy, but then also tying in the CAR T therapies. They're on the horizon. And again, we're about to start a study here at Pittsburgh. So that will be exciting as well.
Cassie, this was so helpful. We talked about what to think about with patients who, if they came in, let's say, with just fair to thrive, and then have reflux, and then why we think about scleroderma. One of the things you kept saying was these kids don't complain.
Mhm.
In today's world, we don't hear that very often. So can you talk about that a little bit?
Yeah, it's just shocking. So, I mean, really, your physical exam is your best friend. So please, I hope this generation does a good exam. Really just kind of looking head to toe, checking the kid out, checking their function, having them I've learned so much just you've seen if you ever stop by a rheumatology clinic, we're like having the kids run down the hall, right? So some
Yes.
of that's for juvenile arthritis, but some of that's for dermatomyositis and scleroderma. You learn a lot by watching a kid get up and down an exam table. You can tell if something has a contracture, they're not using their weight, they're not holding something correctly. So use your observational skills. Get away from that computer. Sorry, I have to say it. It just drives me
Yeah.
nuts. Like people just jump and they're so stuck on their note. Like just stop and do the exam and do the right way and have the kid run around the room, move some things. Hey, have them draw something on a tablet. That's how you're going to learn these subtle things and you can see how sick they are. And then you just have to unfortunately, you have to learn to ask the right questions because the kids aren't going to offer. So, for example, for the reflux when it's really bad, we basically say, oh, do the classic chest burns symptoms, and they're going to say no, no, no. But you say, do you sleep with a couple pillows? Oh yeah, she sleeps upright pretty much, like she's sitting in a chair. Okay, it's because she has wicked reflux and she can't lay flat or else all the acid in the food is going up into her throat and she's coughing.
So fascinating.
Yeah, the family will say, "Oh, yeah, we notice when she doesn't sleep with all those pillows, she's coughing all night." Yeah, because she's silently aspirating. So, yeah, you just have to start getting a little nuanced of how you ask the questions, and then it gets a little bit more so that's more of the reflux, but as far as you can tell a lot by, like, their limitation and the deep musculoskeletal and skin involvement by doing a good exam. There's other key things too. There's like in darker color skin patients, they get dyspigmentation, both hyper and hypo. We call that salt and pepper. Some of it's like behind their ears or on their neck or kind of low on their chest. So again, you have to kind of do the full exam to see some of these subtle findings.
Has been so helpful. Now, Cassie, I always give our guests the final say, meaning if there's something we did not talk about that you wanted to talk about, feel free.
Yeah, I would say, I try to whenever there's a medical student or resident or somebody rotating in the clinic, even if they're with one of the other attendings, I try to say like, "Oh, come over and see. This is an interesting clinical exam finding." So whenever folks are kind of inpatient or outpatient, they have the opportunity and they do have a patient with localized scleroderma or systemic sclerosis, please use that opportunity to like teach the other folks around you. A lot of my patients come from all over the country, so they're kind of used to having lots of people in the room. And then when I do ask them, they're like, "Oh yeah, we're used to it. This was done at wherever in California or Chicago." So it's okay, like, that's and they know, they're just trying to learn so that when they see it, they'll know what it looks like. So that would be kind of a little tip that I would mention just to help kind of educate folks because it's rare. So when you see it, like, pull some people into the room.
I think that's a great lesson. Especially being at a teaching institution, we love that stuff, right?
Yeah,
Cassie, this was wonderful. Thank you so much for coming on and talking about this.
cool. No problem, Tony. I had a great conversation with you.
As a reminder, free CME is available and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests and special thanks to all of you who take the time to join us. We know that your time is valuable and we appreciate you sharing it with us.
Please feel free to email my dad at tonwalker cy.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.